The first thing that we're going to do today is the visual trick for determining someone's MEA. In lecture on Tuesday, you learned how to use leads 1 and 3 using the compass to determine someone's MEA. Fact, cardiologists don't walk the halls with those compasses and rulers determining someone's MEA. So there must be some sort of trick that allows them to determine roughly a person's MEA. On your exam on Tuesday, I will ask you about this trick. There are a couple of tricks that you could be trained on to do this. I'm teaching you one, and this is the one that I'm going to test you on. If you take an EKG exam, or EKG class, I should say, be ready for them to teach you other tricks. There's more than one way, as we say, to skin a cat. That's kind of bad, right? There is more than one trick. I'm giving you one way. This is the way I will test you on Tuesday. And I will ask you about this forwards and backwards. So on Tuesday, I said by the time I see you on Thursday, please know your 6 leads. Do you remember? So, it's all right. I want to do it this way. Can you please tell me your 6 leads? Lead 1, lead 2, lead 3, AVR, AVF, AVL. All right, okay. So could you draw them on a piece of paper? And remember that if you were drawing them on a piece of paper, remember that it's the patient's right, the patient's left, not your right, not your left. And I said on Tuesday, you should be able to draw all of those 6 leads in a hexaxial diagram. And you should also be able to draw them individually in a circle. Do you remember? So a hexaxial diagram. We have lead 1, lead 2, lead 3, AVF, AVL, AVR. Remember, again, this is the patient's heart shining up to you. So it's the patient's right, the patient's left, anatomical position. Remember that a normal MEA is from -20 to what? Plus 100. That's normal. From -20 to -30, what is that called? A left axial shift. And from -30 until we get to the 90-degree mark, that's a left axial deviation. From 100 to 110, what is that called? A right axial shift. And from 110 to 180, right axial deviation. And what's this area called? No man's land. Why? MEA stands for mean electrical axis. Mean in math stands for average. An average vector to describe the overall direction of current going through the ventricles. It should be down and to the left. if you have current going up and to the right, up and to the right, that means electrical current is starting in the apex and going up to the atria. You know that, like, no person's electrical current should be going up and to the right. That's why we call it no man's land. Good? Okay. So the next thing I want you to do is please draw 6 circles, 2 rows of 3. Please draw your 6 leads that you're responsible for in those circles. For example, here's lead 1. Here's lead 2. Here's lead 3. Here's AVF. Here's AVL. And here's AVR. You should be able to do that on your own by Tuesday. I've drawn these 6 leads on purpose in this arrangement because I can group them in sets of 2. You did not see this coming. It's only because I've been doing this for a long time. But I know how to do this. If I combine them in these sets, I can now draw a circle and do a biaxial diagram. That means two axes. I can draw lead 1 and AVF in the same circle. That's biaxial. When I do that, I get my circle cut into 4 equal quadrants, 4 sets of pi. If I do this for the next set, I get lead 2 and AVL. And the last one, I get lead 3 and AVR. Someone from your class last night said, Kara, I can think of another two leads put together where I get a circle cut in equal fourths. I said, you're awesome. Then good for you. You get this. But this is the combination I will use on Tuesday's exam. Yvonne, you might get the test version where you get lead 1 and AVF. April, you might get AVL and lead 2. Brooklyn, you might get lead 3 and AVL. These are the 3 I will use. How will I use them? I'm going to use them for the cheat method on how to determine someone's MEA. That's what I'm going to show you right now. Are you ready? Okay. Your job, in order to use this method, your job is to know your leads. You're fine. You're fine. You should know your 6 leads. Of course, there are 12 leads that we use in a clinical setting, but it was not Naked Tuesday and it was not Naked Thursday. We did not attach the precordial leads. That means your responsibility is lead 1, 2, 3, AVR, AVL, AVF. and how they orient in a circle, a compass. Remember we talked about this on Tuesday, right? A compass. Do not memorize the degrees that these leads point to. You will have a picture of the compass in your exam. You are expected to determine someone's MEA using the compass, using leads 1 and 3. So you will have a compass on your exam. You can always reference that. Do not memorize the degrees, but do know the overall direction that these 6 leads point to. Lead 1, for example, points to your patient's left. Lead 2 points down and to the left. Lead 3 points down and to the right. AVR points over your patient's right shoulder. AVL points over your patient's left shoulder. And AVF points straight down to your patient's feet. Know those orientations. For the cheat method, you can use any 2 leads, any 2. But using 2 leads that cut a circle into equal quadrants is more powerful. So these are the combinations I will test you on. Lead 1 AVF, lead 2 AVL, lead 3 AVR. Those are the combinations. So Stephanie, you might get the test version where it says compare lead 1 and AVF. Tell me the patient's MEA. Ashley, you might get lead 2 and AVL. Carlos, you might get lead 3 and AVR. Be ready. Of course, I have different versions to discourage cheating. You know that, right? To discourage teaching. I almost said that. To discourage teaching. Yeah. It's hard coming back from spring break. For this set of examples, I am going to use lead 1 and AVF. Clearly, it will cut my circle into 4 equal quadrants. You don't have a ruler. You don't have a compass. Simply look at lead 1. Look at the R and look at the S. Remember, we look at R and S, not Q. Not everyone has a Q. So we don't look at Q. We look at S. We look at the upward deflection for R or downward. It depends on your patient. But we look at the R and we look at the S. We take the algebraic sum. You don't have a ruler. So overall, what would you say for lead 1? Is this overall up or down? Up. Good. So if you had lead 1 drawn in a circle, where would you color in your circle for lead 1 if it's overall up, which means positive deflection? Where would you color that in? Wouldn't you color in this half of the circle? What about AVF? What is that? Overall up or down? Negative. That means negative values, right? So where is AVF negative? AVF is negative here, isn't it? Do you agree? So in your head, you ask yourself, overall, whatever 2 leads I'm looking at, is that particular lead overall positive or negative? Where would that be in a circle if I drew that vector in a circle on its own? Knowing that vectors have their arrows pointing to which side? Positive. And their tails are pointing to? Good. So overall, in this example, lead 1 is overall positive. Lead AVF is overall negative. Now, watch this. Do you agree? Lead 1, overall positive. Lead AVF, overall negative. Now superimpose those two shades. Do you agree with that? So if you look at my picture here on the side, if I superimpose these two pictures, do you agree that I would have a circle where I would have the heaviest shading here? Well, that's where your patient's MEA is, roughly. It's a rough estimate. It's not exact, it's a rough estimate. It's good enough. This would be suggestive of an LAD, left axial deviation. Again, normal is minus 20 to 100, from minus 20 to minus 30 in LAS, minus 30 to roughly 90 in LAD. We will talk about why someone might have an LAS or an LAD in just a moment. Sometimes we're worried, other times not so much. For example, when someone is terminally pregnant with a parasite, that parasite takes up all of their abdominal cavity and squishes the viscera way up underneath the diaphragm. And your diaphragm is roughly at the level of your nipples. And I mean your normal, Yvonne, anatomical nipples, not when you're 50 and they're down here. And we use our bra to kind of scoop everything up. Like, these are my knees right now. That's what they are. No? So tell me someone famous right now that has a parasite ready to be born where... Okay. Yes. Meghan Markle, married to Prince Harry. She's due any time now. My grandmother used to say, the first one comes at any time. The second one takes 9 months. We're not passing judgment on Meghan. But somebody else famous is pregnant too, and she complains having to compete against Meghan. Amy Schumer. Yes. Yeah. Poor baby girl has had a hard time with her pregnancy, and she even in her recent stand-up, she's like, look at my belly, and she's in her underwear, and she's got a Band-Aid over her big umbilicus, and she's trying to. Have you seen that one? Yeah, growing? The other night. Yeah. Not her best work. Love you, Amy, but it's not her best work. But we'll forgive her. It's hard being pregnant. So someone who's pregnant, that parasite pushing up all the viscera, your heart is connected to your diaphragm, which is roughly at the level of the nipples, separates the thoracic from the abdominal region. So if everything's shoved up here,
I don't know if I should be looking or not.
I have nothing to hide. You should know that by now. This is all going to go on YouTube. You were here for it. I have nothing to hide. I have no shame. Anyway, so your apex of your heart is tethered to the diaphragm. So when everything is shoved up, the apex of the heart is going to point more left. So a person who's terminally pregnant might have a left axial shift or even left axial deviation, but we wouldn't necessarily say, oh, you're in a diseased state. No, they're pregnant. We wouldn't do anything about that. Some people are just naturally tall and slender and lean. So their diaphragm might be sitting anatomically more inferiorly. And again, the apex of the heart is connected to that. It might be more vertical in the thoracic cage. So they might have a more right-setted MEA. It does not mean that we say, oh, you're diseased, we should do something about it. We ask these questions, we think about it. Does that make sense? So are you an ectomorph where everything is more vertical, like Cole? Or are you an endomorph where you're like 50-something-year-old woman where everything is smushed up here and over to the side? No? Cole's like, I'm not sure if I should look. Welcome back, honey.
Great to be back.
We have no secrets here. Would you like to do another one? Yes? Okay. What would you say for this example?
Negative.
Yeah, Ashlyn's like, I already did. Please remember that you measure the R and the S, not the Q. And I point that out because AVF, notice the Q, notice the R, and there is no S. Nothing remarkable. And in your lab manual, it even says in your instructions to measure the R and the S. Why don't we measure the Q? Not everyone has a Q. So not everyone will have, from baseline, a downward deflection for the Q leading to an R. But everyone will have at least an R, and everyone has to go from an R to an S. Whether the R is positive or negative, everyone will have an R and has to lead to an S. But not everyone will have a Q. So you only look at the R and the S, and you take the algebraic sum. How many of you don't have many dollars in your wallet or your purse? I don't have many dollars. I might have a few coins. How many of you have $3 in your purse or wallet? How many of you have 50? You might not want to raise your hand. We can think of our leads, of our vectors of any sort, as a number line. This is not the first time I've told you about this. When we think of a number line, for example, X and Y, we know the middle, the origin, is 0. For the X-axis, every digit over here on the left is positive, isn't it? Think of that as positive dollars. How many dollars do you have? +5, plus 50? Do you owe people? Are you negative? So I point that out because if you look at this example, for lead 1, what is the algebraic sum? Negative, overall negative. Very negative, I would say. Clear as day, negative. How would you shade that in a circle if lead 1 was drawn in that circle? Sorry, I'm trying to video record this because some of you have raised issues. Kara, do you know that you don't have all of this recorded? Can you please do something about that? And I'm like, this is us doing stuff. It's hard to record this. So if I have lead 1 and it's overall negative, which side of the circle would you record this? Would you shade it this way? And isn't AVF your perpendicular bisector, as I call it? Okay. So how would you shade that in for AVF in this example? Do you look at this? No, because that's Q, isn't it? Here's your R. Is there an S? Not really. So overall, is this positive? Robustly positive or ish? Ish. So how do you do that? If AVF points down, and this is 0 for AVF, and you're saying it's ish positive, do you agree with my shading right here? And so this would be an RAD. So you can actually use your qualitative terms and shade it appropriately and have a way to distinguish where your MEA would point. And this would be a right axial deviation. Now, on your exam, I will, for sure, ask you a question or two on how to determine someone's MEA using this cheating method, this visual method, without using a compass. You do not know what version you're going to get. Again, Carlos, you might get the AVR and lead 3. Ashlyn versus Ashley. Ashlyn, you might get AVL and lead 2. Julie, you might get lead 1 and AVF. That's the forward method. You telling me, based on the 2 leads I give you, what the MEA would be in your patient. Then I will ask you a question or two on the backwards way. How do you process this backwards? If I tell you which 2 leads you are using, if I tell you the MEA of your patient, can you tell me if the pen would be overall up or down? Can you tell me that? How do you do that? Go in reverse, work backwards. And you're all looking at me like, don't know what that means, so show me. Okay, I'll show you. But I'd like to think that you'd be able to figure this out on your own. If I told you you were playing with lead 1 and AVF, for example, I would expect you to draw a circle with lead 1 and AVF in the circle. I'm telling you which 2 leads you're playing with. if I tell you that the patient has a left axial deviation, I would expect you to know where that MEA would point. Left axial deviation, according to Kara, is somewhere over here-ish. Agreed? Okay? So then I say to you, tell me, lead 1, would it be overall positive or negative deflection? Well, all you have to do is say, well, here's my MEA, and this is overall positive for lead 1. It's on the positive side, isn't it? So you would say upward deflection means positive deflection. What about for AVF? What side is this on? Negative. So you would say for AVF. AVF, you would say overall negative deflection. Correct? Okay. So some of you, depending on the look, these are the only 3 combinations I will give you. I will tell you the MEA of the patient. It will be an RAD or an LAD. Clear? Okay, so if you play with these 3 possible combinations and play with an RAD or an LAD, some of you who are doing your job right might say, Kara, I could see possibly 2 potential answers for some of these. I will not give you 2 potential answers. There will only be 1 possible answer. Some of the other answer choices might be nonsensical. I am positive that I have a negative attitude to this whole exercise. Don't pick that one. Okay? So if you play with these 3 potential leads scenarios, an RAD or an LAD, when would it be an upward deflection or a down? There are only so many finite possibilities. Do you see that? This is not an infinite question. It means you could actually practice and get these points under your belt. Clear? So to recap, out of a potential 30 points, and this weekend I will tell you how big your exam is, but I'm just using 30 points as a global idea. If it's 30 points, clear as day, 2 points for calculating heart rate. To remember, 1.5 points for showing me your work on lead 2. 0.5 point for boxing your answer with the correct units. 2 points for calculating someone's MEA using the compass, using leads 1 and 3. That means on the EKG, I need to see your measurements and your algebraic sum. 1.5 points for showing your work, 0.5 point for showing me your overall MEA. What are the units for MEA? Thank you. 2 points for calculating an interval or a segment, which we need to do tonight, and we will. 1.5 points for showing me your work, marking on the lead 2 where you began your measurement and where you ended, and boxing your answer with the correct units. The correct units, Yvonne, for an interval or segment are seconds. So it's the element of time. 5 points on the multiple, like Scantron part, multiple choice, telling me if the pen would go up or down. We practiced that All of you have practiced that already. Tuesday class, we did this. Thursday, we did this before spring break. Would the pen go up or down? If the pen goes up, you mark letter A. If the pen goes down, you mark letter B. That's 5 points. Can you rely on a pattern? If the first one is up, the second one is always down? No. Good. Will I create a lead? No. But I did tell you, if you really know your vector analysis, if you really know your shit, I could create any lead I want and put next to it the cardiac vectors. There are only 5 cardiac vectors I've asked you to know. You should be able to tell me if the pen goes up or down. I will not create a lead. You will be held to the 6 I've asked you to know. But if you really know your shit, if you're studying with each other, have someone create a lead and say, now what will the pen do? About 8 to 11-ish questions on the Scantron part will be matching. I told you already, some of those matching questions will be to the electrical vents and what they mean. Do you remember? Let me show you. I'm just going to go backwards and then I'll come back to this slide. Do you remember this slide? The electrical events, like the P wave, represents atrial depolarization. What will happen as a result of the P wave? The atria will contract. We will get the last 20% of blood filling into the ventricles. Those 8 to 11 questions should be easy. It doesn't get easier than that. And I'm telling you, I'm taking it straight from here. It doesn't get any easier. I will go over this slide in just a moment. I will also go over the segments and intervals in just a moment, but these will be answer choices as well, and you will match them to descriptions. It doesn't get any easier than that. Past students will tell you, oh, the other third of the exam that Kara isn't really telling you anything about comes from your homework packet, the first 2 pages, where she already has given you the answers to those first 2 pages. And if you really want practice, type in to any internet search engine, cardiac cycle. Find practice exams or quizzes to the cardiac cycle from publishers like McGraw-Hill or Pearson. I know I did. And that's where I got those first 2 pages of your homework packet. So look at them. They are going to test you on ideas that are not new ideas to you. You've heard me say them over and over, and you're getting complacent. Why does blood flow? From pressure differences? How does blood flow? High to low. Okay, then make sure you mark that. The question is going to sneak attack you, and the answer choice, you're going to be like, I don't know, it doesn't read the same. Yeah, go back to what you know. Blood flows from high pressure to low. Why do valves open or close? Pressure differences. Then make sure you mark that freaking answer. Where do we find delays in the heart for the conductive system? AV node, and where else? Bundle of His. Make sure you mark both of those, even if I don't tell you, because I'm telling you now. Good? Who volunteers to just miss that one? Michael, don't raise your hand, honey. It's like, I think I'm stretching, but maybe not. When you review your EKG test, and I say, why did you do that? You go, oh my gosh, you warned us, Kara. And I'm going to say, yeah, I did. A monkey learns more quickly than you do. Why did you do that? I warned you. I said, I don't know. I just, it was the test. I just didn't. It's not funny when your brain plays a joke on you. It's not funny, is it? It's not funny. Okay, so let me finish when we see a change in MEA. The last slide. In your lab, I asked one of you at each group to hold your breath in or hold your breath out. Remember that? When you breathe in, your diaphragm contracts and it moves inferiorly. When that happens, the pericardial membranes are attached to the diaphragm. The apex of the heart moves with the diaphragm. And when you breathe in, your heart will be more vertical in your thoracic cage. So that means, compared to normal, your MEA will be more to the right. Your patient's right. When you exhale, the diaphragm domes up. That's the position it has when it relaxes. The diaphragm will now push on the apex of the heart. It will move more towards the left, and your MEA will be more towards the left compared to normal. So when we have a break, I encourage you to use more of those compass pictures to actually map out the person in your group, their normal MEA, and then use 2 more pictures to map their MEA when they held their breath in. The MEA should be more towards the right. And when they exhaled and held their breath, their MEA should be more towards the left. It doesn't always work. It depends. You all have a lot of fun in lab and you start giggling and you start laughing. But it should have worked, and that's what I will test you on. It should be that for a breath in, your MEA goes to the right. For the breath out, your MEA goes more towards the left, okay? When else can we see an MEA that's moving more towards the right or the left? Ectomorphs, tall people like Kyle, more towards the right. Endomorphs, more towards the left. Pregnant women like Amy Schumer and Meghan Markle, more towards the left. But there are, being pregnant, being tall, or being portly are not disease states. Although I'd like to think that being pregnant is a disease state, technically the medical world does not see it that way. I think it's that way. If I had enough money, I would have paid someone to carry my children. I did not like being pregnant. I love the child. Give me the child. Give me the child. I don't even need the baby. Give me the child. Give me the child. Love the child. Hate being pregnant. Give me. Do you want to be my adopted child? Okay, good. Ashley's like, yes, I will take good care. Give me the child. I don't care how old. It's the same thing with a dog. Give me the dog. I don't need the puppy. Give me whatever dog. I'll take whatever emotional baggage they have. Give it to me. I'll take that. But are there disease states that can lead to a right versus left? Of course. And up on the screen, I'm showing you a bundle branch block. If there is a right bundle branch block, shown over here, you can see the white mark right there, then that means the left side of the IV septum will depolarize faster than the right. And that happens normally anyway. But now, if the right bundle branch is blocked, the right side is really going to be behind the left. And that means the right ventricular wall will really be behind. And that means those cells on the right side will be holding positive surface charge. And remember, that's where our vectors point. So a person with an MEA that is way over here at, say, beyond 110 to like maybe 140, that means the right side is sitting there going, waiting for the electrical current to get there. Longer than it should. Beyond normal, reasonable expectations. A left bundle branch, shown over here, then that means the right side of the IV septum will depolarize ahead of the left. That's not normal. I ask questions on this. So if I have a left bundle branch, the right side of the IV septum will depolarize first. That's not normal. And that means the left ventricular wall will be waiting even longer for the action potential to reach it. Longer than normal. Already the left ventricular wall is behind the right ventricular wall. Are you listening to me? Because I'm being clear as day, saying right IV septum versus left IV septum versus right ventricular wall versus left ventricular wall. I am being clear. And if you're daydreaming, you missed all that. And it's a good thing that I'm recording everything. Even to my own humiliation. Left bundle branch block, left ventricular side, waiting even longer for that action potential. Then the MEA is going to point that way. Vectors point to positive surface charge. Good? Okay. I'm going to back up in the PowerPoint. I'm going to go over the electrolyte imbalances. This will again be a matching section. You have a slide that does the 3 hypers and 3 hypos. Hyperemias, hypoemia. Emia means in the blood. So we're talking about the plasma. The plasma is an extracellular body fluid compartment. Look, we're at the point in the semester where we are going back in time to our previous lecture units. You don't have the luxury of deleting your memory cells. Everything builds from here on out. Everything. Emia, in the blood. Hyper, too much. Hypernatremia, too many sodium ions in the plasma. Sodium is already abundant extracellularly, but now we're talking way too much. Hypercalcemia, too much calcium. Hyperkalemia, too much potassium. This will be a matching section. If you have hypernatremia, I need you to know that the sodium can bully its way through the calcium channels. When the calcium voltage gated channels are open, if you have too much sodium, it can wiggle its way through those channels, and that means calcium doesn't get in. And the heart tissue will be weak. Why? Because we don't get calcium to bind to troponin and remove the inhibition of tropomyosin. And if you don't do that, how do you get actin and myosin to interact? You don't. And the heart will be weak and flaccid. Inotropy will be down, negative. Hypercalcemia. We see a negative, positive. Negative chronotropy, reduced heart rate. Positive inotropy, increased force of contraction. Let's start there. Increased force of contraction. We're getting more calcium coming in. Why? We have so much out in the T-tubule. It's removing the inhibition of troponin and tropomyosin. The heart is generating a greater force of contraction. We're getting a greater stroke volume. And the brain is saying, you're so good at this. Do you remember this? Who was I talking to on the Tuesday? Was it Brooklyn? No. I thought it was. Look at her. She's like, no. Who was it? That's right. That was Leslie. So if the heart contracts and it's so good at getting that stroke volume, the brain, remember Tuesday class, talks to the heart and goes, you're so good at this. You're so good. And the heart goes, I'm good at this? And the brain goes, yes, you're so good at this. You should take a break. Remember when Leslie asked about the stroke? And so the heart goes, I'm super good at this. I should have a break. If it has a great, vigorous stroke volume, if Tuesday class, if I only need $1, but all I have are quarters, how many quarters do I need? Good. Tuesday class, if I need $1, but all I have are dimes, that's a lower denomination. How many dimes will I need? More, won't I? Thursday class, cardiac output needs to be 5 liters per minute. We calculate that by multiplying stroke volume by heart rate. The Tuesday class would say to you, your stroke volume is the denomination of your coins. Do you have 25 cents? Do you have a quarter? Do you have a dime? If I have 25 cents, then I need 4 quarters, don't I, to get $1. If I have 10 cents, what do I need? I need to compensate with more of those lower denominations. Stroke volume and heart rate is a lot like your coins, what denomination, and how many you would need. The overall outcome, your cardiac output, for us, we need not $1, we need 5 liters per minute. So if the heart is super good and gives you a robust contraction, then the brain says, oh my gosh, you're super good at that. You're so good at that. You got so much out, you can take a break. You do not need to beat as often. But if the heart becomes weak and flabby and the stroke volume goes down, guess what the brain is going to say? You lazy son of a bitch! If you can't be bothered to kick out the stroke volume that I need, then you're going to compensate and you're going to do double time. And now the heart is working harder. And logically, any tissue that's working harder should have more oxygen going to it, more nutrition going to it, more blood flow. But what's the rub with the heart? The coronary arteries are traveling in the cardiac sinus. That's the space in between the atria and the ventricles. And when the heart is contracting, it compresses on the coronary arteries. It is only during rest that the heart gets a well-deserved break, the ventricles fill, and we get oxygen and nutrition to the ventricles. A harder working tissue should get more blood flow, not less. And yet that's what we do to our heart when our heart rate goes up. Now that's a good thing when we're working out. We're building up our heart tissue. That's a bad thing. If you have an elevated heart rate at rest, why? To what end? What need? That's diseased state. Should not happen like that. So with hypercalcemia, vigorous contraction, more stroke volume, and the brain says, oh my gosh, you're so good at this. You deserve a break. Chronotropy goes down. Remember, the first value is chronotropy, second is hyperkalemia. Sorry. What I want you to know is on an EKG, we would see tented T waves. Instead of sloped, we would see a peak. That's all I want you to know, tented T waves for hyperkalemia. What about your hypos? For hyponatremia, it would take longer for us to reach threshold. We would see a delay, an abnormal delay. Heart rate would go down. So chronotropy would be negative, slower heart rate. Hypocalcemia, we would see a weaker heart, less vigorous of a stroke volume. Stroke volume would go down. The brain would say to the heart, you lazy son of a bitch. If you can't be bothered, then you need to compensate double time. So chronotropy would go up, inotropy would go down. Hypokalemia, we would see a U wave on a patient's EKG. Now, what is a U wave? Now, most students, when they think the letter U, they think, oh, on an EKG, I would see this. Doesn't that look like a U? That is not what you see. You actually see the pen going up. And students say, what the duck? Why then do we call it U? It's not going down like a U would go down. It's not the shape of the letter U. It's because U is the letter after T. That's why we see a U wave. And what it represents actually, and this is not new to you. You're super smart people. You know vector analysis. Welcome to the club. When we see a U wave, it's because the ventricular repolarization has now separated into two phases, ventricular walls and IV septum. That's not new to you. It's not new to you. Ventricular depolarization had three different vectors, Q, R, S. When ventricular repolarization is not as fast as it should be because of electrolyte imbalances like hypokalemia, then we get separation of the ventricular wall versus the IV septum, and now we get ventricular vector and IV septum vector. And that's why we see the T and then the U. I do not ask you to explain the U wave. I merely want you to know that the U wave is an outcome if a person has hypokalemia. That's it. It's a matching question. Good? Yes? Okay. So we have reviewed the cheat method. We have reviewed our electrolytes. We have reviewed why we have a left versus right axial deviation. Before your break, let me talk to you about another matching section. And when you return from the break, I will tell you about your intervals and segments, and we will also finish the cardiac cycle lecture. Arrhythmia versus dysrhythmias. A lot of physicians, a lot of clinical personnel interchange those words. Arrhythmia means no, zero, none, electrical current. That means if you don't intervene, your patient's dead. Do you understand that? Arrhythmia means no current. Dysrhythmia means you have current, but it's not traveling in the way that it should. And we've talked about this down and to the left, around the ventricular walls. We've used those terms. But a lot of times in a clinical setting, they interchange them. I don't care. So let me tell you about some types of dysrhythmia/arrhythmias. This means abnormal current flow. Tachycardia, an abnormally elevated heart rate at rest, more than 100 beats per minute at rest. This means without caffeine, just you being calm blue ocean, you have a heart rate more than 100 beats per minute. Again, this is going to be a matching section. It doesn't get easier than this. Bradycardia, a heart rate, resting heart rate below 60 beats per minute. Incomplete atrioventricular block. First degree. Okay. So atrioventricular block means we have a conduction block between the AV node going to the ventricles. There are different degrees of severity. There's first degree, second, and third. Your lab manual asks you about all three. On your exam, I will only ask you about AV nodal block 1, degree 1, first degree, or third degree. First degree means your PR interval is more than 0.2 seconds. When you come back from your break, I will explain what that means. More than 0.2 seconds for a PR interval is suggestive that your patient has first degree AV nodal block. When the atria and the ventricles are completely dissociated, when they do not have syncytium, then that's considered third degree AV nodal block. You would see a P wave after P wave after P wave, and then a QRST. I'll remind you of the perverted experiments that I did as a graduate student. When I took fetal mice and I took their hearts and I minced up their hearts and I plated their heart cells in petri dishes. And I told you that some cells would ball up on their own and then flatten out, and other cells were just healthy and alive but didn't move, didn't contract. And it wasn't until everything was confluent that the whole sheet of cells would contract and then flatten out. Remember that? Contract and flatten out. I asked you before spring break to actually draw out the slope of all the specialized cells. I said every single specialized cell has its own pre-potential. Do you remember that? And I said draw it. And we talked about the steepness, the rise over run for the slopes of the pre-potential. The steeper the slope, the sooner you would reach threshold. Do you remember? The less steep, the longer it would take to reach threshold, the lower the heart rate. So if all of the specialized cells can reach threshold on their own under normal conditions, if we somehow have a barrier between the atria and the ventricles, then that means the Purkinje fibers are going to reach threshold on their own with no influence from anything higher from the atria. Remember, the cells are supposed to be connected through intercalated discs. So if there's a blockage, then the atria will reach threshold and then have their mechanical events on their own, and the ventricles will be left to their own devices. We will have total dissociation of atria and ventricles. That's third degree AV nodal block. Dissociation of P waves from QRSTs. The atria and ventricles are no longer communicating. The atria have no influence on the ventricles. Good. Go have a break. I'll see you in 10 minutes. We're going to finish the cardiac cycle lecture, and we will also talk about intervals and segments. I'm going to do intervals and segments first because that's important for Tuesday's exam. If I don't finish the cardiac cycle lecture, I don't finish it. That's not important for Tuesday's exam. Okay? Calm blue ocean. Okay.